All right. Thank you, everybody, for tuning back in. This is video 2 of week 1 and 2 of Gastroenterology. And we're starting on page 6 or so with cholecystitis. Cholecystitis, which is what? Inflammation of the gallbladder, right? Inflammation of the gallbladder. And you can see there's a little bit stages of gallbladder disease. Asymptomatic gallstones. Most of us probably have some gallstones, but really never a problem. Then you can get some blockage. When you get some blockage, you get inflammation, and then you actually get the actual stone lodged in the common bile duct. All right, so the key when it comes to the gallbladder, okay, is we need to keep things moving through there. There are some things that stimulate the gallbladder. For example, supplement-wise, on the top of the list is actually curcumin. Curcumin. In fact, if you ever purchase curcumin, you'll see it's the one caution. People who have gallstones or kind of gallbladder issues should not be using curcumin because it causes the gallbladder to contract. Curcumin causes gallbladder to contract. So it's very useful. Olive oil. People, a lot of times I just have people taking a spoonful of olive oil with their meals, which helps move things from the liver through the gallbladder. So olive oil. But coffee, tea, also stimulating for the gallbladder. And gallbladder issues, it's one of those things where some people never get an issue, and yet some people are constantly plagued by the issues. I think we'll talk about gallstones in a little bit further, so I won't go into the details. But it's generally how it works. Either no issues or a lot of issues. So, and it works the same way with kidney stones, by the way. Some people just go through life and never have had a kidney stones, and other people constantly get them. So it has a lot to do with body chemistry. In this case, what's going on in the liver. So a lot of liver support. Okay, take a look at your cholesterol levels. Make sure your liver is working optimally. All those waste products from the liver get dumped into the gallbladder. Okay. And again, how is this diagnosed? With an ultrasound. With an ultrasound. If at all possible, we really want to try and hold on to that gallbladder. Why? Because the gallbladder, the bile cholesterol, it helps to break down your fats. So people who don't have a gallbladder start getting a deficiency in their fat-soluble vitamins like A, D, E, and K. So we don't want that. So if anybody's had their gallbladder removed, hopefully they're using ox bile along with digestive enzymes to help with the breaking down of food. Now, here's the thing. If someone, and this should be part of your intake, I always ask, you still have your gallbladder? Sometimes people absolutely forget they've had it removed because it's such an incidental type of surgery these days. But if they don't have their gallbladder, what's happening? There's a constant trickle of bile into the small intestine because it doesn't have that storage container. So because that bile is very strong, right, because it breaks down, it's an emulsifier, it can be irritating to the stomach lining. So a lot of times if someone complains, I don't know, I always have just a little bit of irritation all the time, or a little bit of diarrhea. Do you still have your gallbladder? No. Well, it could be because of all this constant trickling of bile. Okay, so something to keep in mind, which means we need to do what? Provide more support for that small intestine, right? We got to provide more support for those cells that are lining that so that they stay healthy. And try to do as little damage as we can by eating a healthy diet and using digestive enzymes and all the things we'll talk about when we get down to the GERD. All right, appendicitis. We kind of mentioned that up in the first video. Here's the thing about appendicitis. If anybody comes in with any kind of abdominal pain, the differential diagnosis, appendicitis is always like on the top of the list until you've ruled it out. Because appendicitis, when it first starts, is actually very diffuse. It's just kind of all over if someone doesn't feel good. It's not just at McBurney's point, right, or Wapsing's, right? It's kind of all over. And as it progresses, it kind of starts narrowing down to that one, that lower right quadrant. So just keep that in mind, and then look at the age. So if someone is, I know this says, what does it say here? A couple of days, it doesn't say an age. Later teenage years. So if you see someone later teenage years, I typically always think 20 to 30. So if someone 20 to 30 comes in and they have abdominal pain, first thing on my list is always appendicitis. So that would be something you want to make sure you refer out. So even if there's no rebound pain at McBurney's point, it's kind of diffuse, they're in the right age, you've ruled out any kind of trauma, you want to maybe kind of move them along to at least have an ultrasound to look at it, right? Because you just don't know. So you don't want to start doing some kind of treatment on them to see if you can take care of it if you think that it possibly could. It's better to have them go get a ultrasound, rule that out. Yeah, it's not that. Okay, come on back, and let's develop some treatment for you. Pancreatitis, kind of talked about that a little bit already. And what is the main reason to see that this happens? By the way, what's the big thing? When you have a gallstone, you have a gallstone that blocks the common duct. So the duct from the pancreas and the gallbladder kind of meet up, and if a gallstone gets stuck right there, all the digestive enzymes from the pancreas can't get out. So they start backing up into the pancreas, and then they do what? Well, they break down proteins and fats, so they're going to start breaking down the pancreas, and you get inflammation. So pancreatitis, first thing you're going to investigate is the gallbladder issues. Okay. CT scan, like I said, today they'll probably do ultrasound with the endoscopy to look at, what's going on with that pancreas. Pancreas issues can refer to the back as well. So if someone's come in and they got back pain, all right, well, let's make sure, maybe it's a pancreas issue. Diverticulitis. You want to make sure people have a lot of fiber and they're drinking enough water. Small bowel obstruction, as we talked about earlier with the hypoactive sounds eventually. So hyperactive early on, and then it progresses to the hypoactive sounds. So if you don't hear any sounds, remember, also take section by section or quadrant by quadrant. Make sure you spend a couple, 3 minutes before you move on. Sometimes there's a long time gap between sounds in the digestive tract. Abdominal aortic aneurysm. So like it says, it's not a digestive issue, but this is something you may come across when you're doing an abdominal exam. Interesting, just an aside, more cocktail information. I don't know how old most of you are, but so I'm pretty old, and maybe you've seen reruns or the very first episode of ER that came out in like 1990 or 91. This was the big case in that first episode. That one doctor who was training to be the surgeon, I think his name is Eric, had a ruptured abdominal aortic aneurysm. And so a lot of the storyline focused on that. So that's what I always think of when I see abdominal aortic aneurysm. And what you'll feel, right, when you're doing the auscultation, number one, you may hear a very loud heartbeat. So when you're listening for the stomach sounds, but you may hear, oh wow, it sounds like I'm listening to the heart, thump, thump. It could be the aneurysm. Okay, could be that. But then when you do the palpation, and you're pressing down, especially if the person is thin. And the thing is, a lot of times this mostly happens in older people, and they may be pretty small and pretty frail. So when you push on their stomach, you may just feel a pulsing sensation, and they may know. You can live with an abdominal aortic aneurysm, by the way. So your aorta can get an aneurysm in several spots. You can live with it. It's nice to have found it, and then what they do is keep an eye. They measure it. As long as that bulge stays, I believe it's 4 centimeters or less, there's no surgery. Okay, so every year, depending on a person, you go in once a year or maybe every 6 months. They take an MRI. They measure that the width of the bulge on that aorta, and if it's still under 4 centimeters, they're just monitoring it, and they're keeping your blood pressure low, right? Because high blood pressure is going to do what? Put more pressure on that bulge. The esophagus. 10 to 13 inches long, diameter 3/4 inch. So you have an upper esophageal sphincter and then that lower esophageal sphincter, and that's where a lot of the activity happens when we talk about several of these pathologies. So dysphagia, right? Difficulty swallowing. And why would that be? It could be from pain, and think of it as maybe irritation. So if you have GERD, which we're going to talk about here in a moment, and you have some inflammation along that esophagus, it's going to hurt, right, when you swallow things, right? Because you have like an open wound, and things going across it are going to make it hurt. Let me see what I'm going to mention here, because I don't see it mentioned here. But if someone has difficulty swallowing, oh yeah, there's it over here. One of the things that you want to always be mindful of is that they could have cancer. And it doesn't have to be cancer of the esophagus, but if they have a growth that is in that thoracic cavity, could be lung cancer, it could be just growing there in the chest cavity, that growth gets big enough and it pushes on the esophagus and creates a smaller opening. So when you go to swallow, that's hard. Now it's really one of those things where you come across cancer, and this is why cancer is usually not really found out until it's well advanced, because you never know you have cancer until you go in for some other checkup. So this person might go in and say, oh, I'm having trouble swallowing. Oh, let's do x-ray, let's do MRI, and they see there's a growth now that's pushing on the esophagus. The other thing to think about when it comes to dysphagia or just any problem with swallowing is that your esophagus, and this is important in older, seniors, your esophagus is attached to your spine, basically. So if you've ever noticed in people who get the kyphosis, they get the rounded back, well, because the esophagus is attached to that esophagus is getting under tension. It's getting kind of stressed. And that can irritate the esophagus as well, and cause some difficulty with swallowing. So look at the person as well, and remember, that's right where the anatomy comes into play, and you understand, wait a minute, the esophagus is attached to the spine. Do they have some kind of spine issue? Did they have a car accident? Right? Did they have some back surgery? That could affect the esophagus as well. And then achalasia is when it's just difficult to swallow, and it's usually not because of a physical thing, right? It could be a nerve issue. Okay, it could be a nerve issue that might be causing the whole process of swallowing is a very coordinated mechanism, right? From your mouth on down, there's this very complex series of steps that take place for you to chew food, move it to the back of your mouth, and swallow it. And if there's something going wrong with that, it's usually, that could be a brain tumor. Maybe they had a head injury or head trauma. Those would be all things that would be on what you want to investigate when it comes to just not being able to swallow. Okay, and then failure of the LES, the lower esophageal sphincter, to relax, and so food sits in the esophagus, and then that causes enlargement of the esophagus, and that's something you can see on the X-ray. Treatment, pneumatic dilation. So there's a device that has like a balloon on the end, and they can put it down your esophagus, and then where they get to the stricture or the narrowing, they just pump up the balloon and they stretch out the esophagus. So some people have this done like every few months because they have a condition that keeps recurring. All right, GERD. Big topic. Something I deal with pretty routinely on a regular basis. And you can read through this here. This is pretty straightforward. Lung damage. Okay, so I'm going to give you just a little mini lecture on GERD. And I attached a couple of documents on the portal as well, that also, if you just want to, you like reading, more information, but I'm going to give you the synopsis. So Western medicine thinks what? It's too much acid, right? It thinks there's too much acid being made in the stomach, which makes sense. It seems logical. So they give you H2 blockers or PPIs to either neutralize the acid or stop the acid production. But I think, right, and naturopaths and a lot of other alternative practitioners are coming around to understand that more than likely it's from too little acid. Too little acid. Now, I know this doesn't make sense at first, and when you try to explain this to people, they're going to, if you just say it's from too little acid, and they're going to say, well, how can that be? If I have the burning, it must be too much acid. So here's how you explain this to someone. So when you eat, food goes in your stomach, and HCl, stomach acid, is released, which should break down the food. The stomach contracts and churns, mixes with that stomach acid, and it should break down in a timely fashion. If there's not enough stomach acid, the stomach is going to keep churning, but it's like, hey, the food isn't breaking down. There's not enough acid. What happens when that food is sitting there a little bit too long? You're in this really hot, moist environment. That food basically starts rotting. Again, it's fermenting. When food is breaking down, it's not moving on. It's creating a gas. from breaking down. If there was enough acid, this would be neutralized and the food would be moving on. But it's just sitting there, not breaking down at the right speed. So this gas is created from fermentation, from breaking down, from sitting there rotting, and that gas expands upwards, because upwards is where the space is. It's taking with it a little bit of the acid that's being made, pushes up through that lower esophageal sphincter, and then that's when you get the heartburn. So that's how you want to explain this, because people will have a hard time accepting that it's from too little stomach acid. They don't quite understand this physiology, what's happening there. Now, along those same lines, it's really, really important to understand that most people are taking a proton pump inhibitor. Now, those have a whole list of side effects as well. Heart health, kidney health, right? Damaging effects, because that proton pump inhibitor affects the mitochondria, right, in cells. And heart and kidney are two organs that are functioning all the time and lots of activity. So the minute you stop the mitochondria, you're going to cause dysfunction in the heart and kidneys. But the point is, if someone's on a PPI, proton pump inhibitor, you cannot just stop a proton pump inhibitor. If you just stop a proton pump inhibitor, you will get a rebound effect, and you will get too much acid being made. So think of it this way, right? If your stomach, you're not taking a proton pump inhibitor and you're making stomach acid, you take a proton pump inhibitor, which prevents the acid from being made, yet your body wants to make, your body's going to try and override that. Your stomach's going to try and override that and try. Those cells are working hard. They're saying, how come I can't make it? I don't know. I better work harder because my body needs it. There's a feedback that says we need acid. Okay, work harder. But the proton pump inhibitor prevents it. If you take away the proton pump inhibitor, these cells now are engaged in making a massive amount of acid because they've been trying so hard. So at first, there's going to be this enormous amount of acid. So you really have to wean somebody off of a proton pump inhibitor very slowly, okay, so that they adjust. And you may have to maybe use betaine HCl while they're doing that, so the body gets used to having acid, so there's not the big rebound effect. So you just have to be careful when they're doing this. Otherwise, if they're not on a PPI, what do we want to do? We want to give them betaine HCl, right? If someone's complaining, they haven't been taking proton pump inhibitors, we want to start giving them some betaine HCl, and you want to do it with, have them eat a few bites of food, and then take a tablet. Most tablets are 500 to 650 milligrams. Start with one after a couple bites of food. You may need 2 or 3, right? So a lot of times people say, it doesn't do anything because they're not taking enough. They're not taking enough. So that's really important. You've taken too much if you start getting a burning sensation or it feels really warm in your stomach, then you back off 1 tablet. So it's important they're taking enough when they start this type of therapy. All right, so that's important to know. Possible. I'm going to see what's on here. Proton pump inhibitors, treatment. Oh, if H. pylori is found, triple therapy, 2 antibiotics and an antacid. Okay, so if H. pylori is found to be an issue, definitely that is something you want to deal with first, always, right, before you start. And if someone has H. pylori or a gastric ulcer, which we're going to talk about in a minute, you don't want to do betaine HCl because you've already got an irritation in the stomach lining. You don't want to add acid or they're going to feel really miserable. Barrett's esophagitis. I'm on page like 13. And that's just when the normal squamous non-mucosal cells of the esophagus transform into columnar mucus secreting cells that are abnormal in structure. Why? Because of GERD. Okay. So GERD causes erosive damage to the esophagus. Okay. Cellular ablation, mucosal resection, cryotherapy. So you don't want really things to progress to that level of irritation, okay, where the cells start changing from one type to another. Esophageal varices. So in a nutshell, what's going on here? So you have liver disease. You have a liver that is a fatty liver. It's got cirrhosis. It's not functioning well. Okay, and it takes quite a bit to damage the liver. But once the damage is happening and the liver is not all functioning, blood is returning through that hepatic portal vein. Okay, so all the blood is coming to the liver through this vein, but the liver is congested. It's damaged. So that blood that wants to get in there can't get into the liver, so it's basically backing up. Okay, it's backing up through the whole body, through the whole system. So these veins are getting very engorged. And the veins that are very sensitive are the ones around the esophagus. And this is how you get the esophageal varices. So that we have to do what? And you see some of the signs and symptoms there. Some of the things we've already talked about. And so that the liver has to be addressed. And then there's very specific things you can do for the varices themselves. Ligation, which actually take those particular veins out, or sclerotherapy, where they're actually going to go in and maybe use a cauterization to take care of those bulging. So think of this as hemorrhoids in your esophagus. All right. And it's caused because the blood is backing up from the liver because the liver is congested. All right, let's go with conditions of the stomach. Hiatal hernia. It's, it's, be surprised how many people tell you they have a hiatal hernia. Most people don't know it. And again, this is one of those incidental findings when people go in for some other type of MRI or CT scan for some other issue and you got a hiatal hernia. Or endoscopy, right? Their stomach has an issue. Doctor goes down, you have a hiatal hernia. Maybe that's what the problem is. Bothers some people, not others. It occurs fairly frequently as people get older, by the way. It's one of those things when people get older, they get up over 80, we start seeing them more frequently. And they're saying causes are trauma, obesity, pregnancy, weightlifting, straining with the bowel movement. So what do you do? Dietary changes, probably the big issue, and making sure you have adequate stomach acid. So you want to make sure, because that lower esophageal sphincter is compromised, you don't want a lot of fermentation in the stomach. You want to make sure that the food is breaking down and moving on and not sitting there and causing gas to push upward. So making sure you fix that. There is a chiropractic move that can bring that piece of the stomach out of the diaphragm. Um, it's sometimes you can just jump off a chair. Okay, I shouldn't tell you that, but you could, right? You could. But sometimes they'll do is have people drink a whole lot of water, so there's a lot of weight in your stomach, and then you jump off a chair, and that should cause the stomach to come down. So I'm just sharing that with you, but don't be spreading that around. But it could work. Gastritis, basically you have inflammation inside your stomach, and this could be a peptic ulcer. It could be a peptic ulcer. I was going to see when I was going to stop here. I'm just go a little bit more because we hit that 30 minutes. So let's just talk about gastritis. Which population, or let's say which country, has the highest risk for gastritis? Anybody know? That's more cocktail information. It used to be Japan. Now it's Korea. So Korea's first, Japan is second. Why? Because they eat a lot of foods that are preserved with nitrates, a lot of salty foods. So that ranks up there as one of the common causes of that. They also have a lot of stress too, right? A major stress in the Japanese people. They work hard, long hours, and that's not helping because they're probably making less stomach acid and they're getting irritations in the stomach, and that's probably compounding the issue too. That would be just my guess. So treatment, stop drugs if possible, H2 blocker or PPI. And, obviously this is one of those cases where they give you this because they don't want you to be making a lot of acid, because the acid keeps irritating the open wound. That's what gastritis is. You have the mucus layer has worn away in a little spot, and now you've got right there to the stomach lining, and it's like it's raw. And if you put acid in that, it keeps irritating it. And NSAIDs are one of the main causes of that, because NSAIDs do what? In case you were ever wondering why, what's the caution? Always with aspirin and GI issues, and it causes bleeding. NSAIDs, it's not the NSAID in the stomach itself that's sitting there irritating. It's NSAIDs in your system prevent the production of the mucous membrane. So if you're taking a lot of aspirins, a lot of NSAIDs, then you're not making a lot of that mucus covering, that mucus lining, and there's a higher chance you're going to irritate your stomach lining. Okay? So caution with that. So some people are more sensitive. I'm sensitive to aspirin and that. So and that's another whole, and here's cocktail information for you. People who take a baby aspirin daily, you could probably get by. Okay, so don't tell people this. This is just for your information, because you're not treating them. You're not going to undo what their doctor tells them to do. But they could probably get by with every 3 days with that baby aspirin. The effects last long enough, but again, it depends on the severity of the issue that the person has. And so you don't want to undo what their doctor has told them. So just keep that in mind. If someone has black tarry stools, ask them, do you take NSAIDs? Yeah, okay, could be why. So anything could irritate that lining, by the way. Tobacco, alcohol, caffeine, spicy foods. Okay, and that will make all that gastritis even worse. And complications, we talked about the perforation. So if you have this gastritis, you have irritation of the lining, you keep irritating it, you keep putting stomach acid on it, it eventually could actually wear right through to the abdominal cavity, and now you got a major infection. Smoking increases the risk as well. And it says people with type O blood and are more risk for duodenal ulcers, type A blood, gastric ulcers. I've not heard that before, but I might have to look up that and see what the studies are for type O blood and type A blood. So, by the way, how do you know if someone comes in and, I don't know, I got pain, you've done your workup, you've asked a lot of questions, and you're trying to figure out what's going on with them, and you ask them, well, when do you have the pain? And let's say they say, well, it's usually... I always ask, is it like when you eat? Is it after you eat? When is it relationship to when you eat? Always one of my questions. If they say, well, it's a few hours after I eat, is that a gastric or stomach ulcer, or is that a duodenal ulcer? So that would be more like a duodenal ulcer. Okay. If it hurts when you eat or drink, it's more likely a gastric ulcer. Okay, so what does that mean? Why is that? So you eat food, and what happens? You release stomach acid, which is going to irritate the ulcer. So that's kind of immediate. And then as the food breaks down over time, depending on what you ate, it's going to move on into the small intestine. May not necessarily take 2 hours, but it'll be sometime after you've eaten. And with it, there's still a little bit of stomach acid with that, and that's going to irritate the ulcer in the duodenum along with the digestive enzymes. So, that might help you pinpoint what it is, especially if you have, and I don't know, I can't remember, is there a specific acupuncture protocol for gastric ulcer versus duodenal ulcer? This may be something you want to really try and figure out. So that's how you would help determine, is it immediate when you eat, or is it a couple hours after you eat, or is it during the night? That could be a duodenal ulcer as well. All right, so I think we're going to stop right here for this second video, okay, at the Zollinger-Ellison syndrome. And then I'll make the third video. I don't want to get too long so that you don't get too tired watching them, and it makes it easier to upload them. All right, so thank you for listening, and get ready for video 3.